Welcome everybody. In this session I will present information from the PowerPoint titled Kinesiology. So at times I'm going to look at the PowerPoint on my other screen because I would like you to go slide by slide so you have a deeper understanding what you are looking for, and I will explain certain PowerPoints perhaps more in detail than others depending on the need and difficulty of the materials presented on that particular PowerPoint. So when you open your PowerPoint, should look like this, titled Kinesiology, and I'm going to right now cover slide by slide. So on the very first slide you have certain statements. Study of movement and active and passive structure involved. That's pretty much what kinesiology is. That's what human motion is. What can we define as structures which are active? Our muscles. They are active, and without them, of course, the bones, which are passive structures or inactive, of course they wouldn't work without muscles. So what else is kinesiology? Kinesiology borrows very heavily from anatomy, biomechanics, and physiology. That's what really kinesiology is. There is no separate science like human motion science per se. Of course, without anatomy, knowledge from biomechanics and physiology, there would be no kinesiology. So combination of all of those. Later on you will realize that it's also a lot of physics and also a lot of mathematics, which I'm going to keep to absolute minimum. In this course, I don't feel that as OTRs we need to have all of this extensive knowledge. So we're gonna keep it to minimum, but to the comfortable minimum, which should be really well absorbed and versed by OTRs. So what's the purpose of kinesiology? Purpose to understand the forces acting on the body in order to manipulate those forces in treatment to improve function and prevent injury. So that's when occupational therapy kicks in, that's where physical therapy kicks in, and that's why it's so important to understand human motion, to understand kinesiology. Okay, let's go to second slide. On the next slide, frame of reference. Well, you know from OTA program what the frame of reference is. It's a bunch of theoretical concepts which are trying to explain or guide our practice according to specifications of special techniques and behavior, and they try to explain the therapist what to do, how to do it, and most importantly when to do it and with whom. So theoretical concepts which explain human behavior, suggest specific treatment techniques, provide rationale for why techniques works. And of course they come with certain assumptions. Let's talk about those in the next slide. So purposeful activities remediate loss of range of motion, strength, and endurance. So what does this mean? Well, that means that as an occupational therapist, if we are asking patients to fold towels, wash windows, brush teeth, comb hair, and anything which it's a part of a goal, either short or long-term goal, and of course comes with accordance with patient interest and needs. This is the assumption of this frame of reference, that as they brush their teeth, they will become stronger and the range of motion will improve as well. And also this works the other way around. When we are working and giving our patients certain exercises, we are doing those exercises with with activities, with real life activities in mind. So if we are giving a patient an exercise for range of motion, we take for granted that if they are do well during those exercises, it's going to translate later in, for example, ADL or IADL or work or leisure or whatever else, or whatever other area we are working on with our patient. It's very important concept is about rest and stress. As occupational therapists, we have to be well aware, especially working with patients, then when patient performs certain activity or exercise, they have to have enough rest. Otherwise, muscles become too stressed or too much toxic. The activity can be, or exercise can be too toxic on the muscles, and they simply won't work. I think the biggest assumption is that biomechanical frame of reference, which is exclusive for kinesiology or human motion, unfortunately takes into consideration only patients with intact brains. Why? Well, let me explain. If you have a patient suffering from schizophrenia, well, usually if there are no additional diagnoses assigned to this patient, people suffering from schizophrenia have no problems with range of motion, no problems with endurance, no problems with strength, no problem with movement. However, they will not bathe, they will not wash, they will not take care of themselves the way they should or is expected them to. Why? Because they are suffering from the schizophrenia. And the same comes with any other patient whose brain is somehow damaged. So again, this is a limitation of biomechanical frame of reference, again used for human motion or kinesiology. And one of the biggest assumptions is that the patient must have intact brain in order to benefit from that frame of reference used in kinesiology. So other limitations, I'm going to slide number 4, separates mind from the body. It doesn't address really anything what is not biomechanical. We do not take into consideration cognition, social skills, emotions. So definitely this is considered a limitation for biomechanical frame of reference. And of course, it doesn't look even at the environment. So in kinesiology, we strictly look at a human body from biomechanical frame of reference as somebody who needs to move in order to complete certain tasks. So let's go to the next slide. We're going to talk about kinematics. Kinematics is a study of motion, and we will spend some time talking about kinematics. So, of course, study of motion in space, and we can, in human body, of course, we can divide them into two major segments, which is osteokinematics and arthrokinematics. Osteokinematics, of course, the name dictates that it's a motion of bones. Arthrokinematics is motion between joints. Arthro, of course, means joint, and osteo means bone. So let's talk about the osteokinematics first. You have two different motions. One is called a translation or linear, interchangeably means the same thing, and the other one is called rotation. So let me give you an example. Bones, well, take into consideration when we are walking, and you're walking from point A to point B. The distance doesn't matter, but for our argument's sake, let's say that the distance is 10 feet. So you transporting yourself from point A to point B in a straight line, that would be considered a translation or linear movement from point A to point B, straight motion, linear or translation. Rotation is absolutely required for you to perform translational and linear motion. What do I mean by that? Every joint which propels you, which allows you to move, uses rotations. So for example, my elbow, the bones rotate around that fixed point or axis of rotation right here. As you can see, my forearm rotates, and this is the axis of rotation. As you can see, look at my fist is going around and comes back in the same round motion. Okay, so this is called rotation. So bones can rotate only because of the characteristics of the joints. Okay, so again, bones must rotate in order to propel you, but when you are reaching from point A to point B, straight line, it's called translation or linear motion. Arthrokinematics, of course, allows for those bones rotations, and we're going to talk about that in a second. So let's go to the next slide. Those are the very simple directional terms. You're well familiar with them. This is just a reminder. Anterior, posterior, superior, inferior, medial, and lateral. I'm not going to go too deep into that because it's just a reminder. Another slide: ventral, dorsal, cranial or cephalic, caudal, proximal and distal, volar or palmar surface, dorsal or dorsum, and plantar surface. Next slide: interior, exterior, ipsilateral, contralateral. Those are very simple terms. Well, they are not simple when you are starting your OT school, but for you it's simple because you are already working professionals in OT field. There is no problem. I don't feel need to go any deeper into this than just read those PowerPoints and just refresh your memory. Anatomical position, it's presented on the next slide, and a couple of slides which are going to be kind of repetitions, but different pictures, different diagrams, but the same information. So the next slide also shows you the anatomical position, and the next slide talks about anatomical planes. And again, everybody probably knows this. I just want to make sure that everybody get that refresher. So we got sagittal plane, frontal or coronal plane, and horizontal plane. So of course, a sagittal plane divides the body into right and left. I like to use a piece of paper to show like this. So right and left, this is the plane, sagittal plane. Frontal or coronal goes like this. Therefore, of course, divide the body into the front and back. And horizontal or transverse, also used interchangeably, plane divides the body into upper and lower, meaning like this. Right, so it's the upper and lower part. So what can we do and why do we learn those planes? Well, because all our movements are performed in space, and that's basically how we divide the space into the three cardinal or principal planes. And of course, we don't necessarily move only in those planes because we can mix those planes. But it's a almost infinite number of possibilities, so we can't talk about all of the possibilities. Therefore, anatomists divided the space into those three cardinal planes. And if you understand those, you understand how the human body moves and why it moves the way it does. So what can you do in sagittal plane? So again, sagittal plane divides the body into right and left, so it's like this, right? So what can you do? The way I like to think about it is, this is like a wall which I can't cross it. Again, I can't bang the wall. All I can do is go with it, but not with it, but not against it. Okay, so what can I easily do? I can do flexions and extensions. I can do flexions and extensions, but nothing else, because I would hit that wall. Okay, so flexions and extensions are performed in sagittal plane. What we can do with frontal plane? Again, back and front. This, imagine this like a wall or invisible planes, but very sturdy, so you can hit them. What can you do now not to hit it? Can you do flexion and extension? No, you're gonna hit. Can you do rotations? No. But what can you do? You can do abductions and adduction. Let me see if I can show you this. This one. I can do abduction and adduction, and I will not hit that wall. Okay, so what can we do with the last one, the transverse or horizontal, which divides like this? Let's see over here. Can I do flexion extension? No. What else? Abduction, adduction? No, it's on my way. What can I do? I can rotate easily, right? So transverse or horizontal plane is for rotation, and this knowledge will become important when we are going to discuss range of motion, manual muscle testing, and other concepts in kinesiology. Okay, let's go to the next slide. The next slide is just shows you what I just described: transverse or horizontal plane, sagittal plane, and coronal plane. It's nicely presented on those drawings. So axis of rotation passes perpendicularly through the plane. This is the most important piece of information. If you remember that, you know it, you done. Passes perpendicularly. What it means perpendicularly? Well, it means right angle. What means right angle? 90 degrees. So I'm trying to show this to you. I like to use a piece of paper and my pen. There we go. There we go. 90 degrees, right? Or right angle or perpendicular to the surface. You can't go this way, can't go that way. Must be 90 degrees. Must be that right angle. All right. So once you remember this, everything else become obvious. Sagittal plane. Sagittal plane. Where is I'm sorry. Where is the pen? Right? Sagittal plane. Where is the pen? Lateral to medial. Lateral to medial. Or right to left. Okay. Frontal plane. Frontal plane. What's happened to my pen or axis of rotation? Anterior, posterior. Anterior, posterior. Or sagittal, or another description would be sagittal. Yes. Then transverse. I'm not changing the position between the pen and paper. I'm just, let me do this. I'm just repositioning everything as one unit. Remember, the angle must be right angle, 90 degrees, right? So transverse or horizontal plane. What's happened to the axis? Up and down, superior, inferior, or vertical axis. Vertical axis. Okay? Why this is important? Because axis of rotation is fixed, right? And plane, we can move in space according to any given plane. So for example, the movement, we discussed that the movement in transverse and horizontal plane is rotation. Look the paper. Can I rotate my paper? Yes, easy, right? But can I do anything else? No. The answer is no. let's say frontal plane, sagittal axis of rotation, or anterior posterior. What we said we can do with that? We can do plane this way or that way, meaning abductions, adductions, right? We're not gonna hit that wall. And the last one we didn't discuss is sagittal, right? Sagittal, right here. So what can we do? We can move this way, we can do this way, but nothing else. So in other words, we can do flexions and extensions, flexions and extensions, and we're not gonna hit that wall. All right, so I hope that demonstration helped a little bit to refresh your memory, because of course I know this material was well covered in your OTA programs, but I want to make sure that we're on the same page. Now the next slide, which is slide number 18, it shows you kind of combination of everything. You can see all the planes and axis of rotation in one slide, on one drawing. Okay, so let's go to the next one. Musculoskeletal motions. Of course, this is a list of what can we do. Flexion and extensions, and of course everything can come with the hyper meaning more than, or hypo means less than. So we got flexion, extension, abduction, adduction, rotations, elevations, depressions. Elevation and depression, those terminologies we're using for shoulders. So I elevate my shoulders and I depress my shoulders. Protraction and retraction we also are using with a scapula and with shoulder girdle. So protraction is forward and retraction is backwards. Okay, horizontal, abduction and adduction. Horizontal meaning your extremity must be positioned horizontally, and I'm going into adduction or abduction, and this is my point 0 or starting point. It's 90 degrees away from your body. Ulnar radial deviation. We of course all know what this is, right? Depending of one side is ulnar, one side is radius, so depending where the movement is going, you're gonna call it either ulnar or radial deviation. Inversion and eversion and inversion, that's gonna be your foot going either this way or that way. Circumduction, this is very interesting because a lot of times people make that mistake, that think that shoulder can do rotation. Shoulder can, but not in the way majority of people think. Like for example, this is not rotation. This, however, is. So what I'm looking for? I'm looking at the humerus, I'm looking at the head of the humerus, which is a part of our shoulder girdle. When I'm doing internal or external rotation, the head of the humerus actually rotates. What type of movement is this then? This is called circumduction, meaning two movements combined in one, which appear to be something else than it really is. Let's explain this. What am I doing right now? I'm doing shoulder flexion, and I reach my potential. That's it. I can't go any further. What am I doing there? I'm changing the dynamics. I'm changing my biomechanics. I'm switching the position to allow my shoulder to go lower. But where I am right now, this is called extension. I can go to extension this way and stop. I can't go anymore. What am I doing? I'm switching the biomechanics and I'm going forward. So in other words, this is not a rotation, not true rotation. It's called a circumduction. Okay, I hope everybody got that, and let's go to the next slide. So again, movement around the frontal axis in the sagittal plane. There are different terminologies, not so much for planes, but for the axis of rotation, as you can clearly see. Different books give you different descriptions, but once you understand the concept, there is no problem. So, in other words, frontal axis, sagittal plane. Flexion, the angle of the joint becomes smaller. Extension, the angle of the joint becomes larger. Hyperextension, extension goes beyond the anatomical reference position. Dorsiflexion, plantar flexion is of course used in your foot. And also bending your trunk. You can bend forward or backwards, and this is of course in the whole sagittal plane. This plane, therefore it's a frontal axis of right to left, right? Okay, let's go to the next one. Movement around the sagittal axis in the frontal plane. Abduction, adduction, we already discussed this. Radial deviation, ulnar deviation, okay, and inversion and eversion, and those are the pictures. You can also see the pictures of the drawings, which show you exactly what the text tells you. Movement around a vertical axis in the transverse plane, and we talk about this, rotations. So safe way to remember it, if you hear the word or see the word rotation, right away, as a rule of thumb, you know that this is transverse plane with vertical axis. Okay, and you got on the slide you got many examples of those rotations. Okay, and next slide, which is slide 23, also shows you hyperextension, extension, flexion. Now, dorsiflexion, plantar flexion, abduction, adduction, and extension and flexion. This is I'm going to give you a correction. This is the only source which I see for wrist extension, flexion, and hyperextension presented in this way. I would like you to disregard this and go with the more familiar, and I'm going to present it to you. This is going to be called for us neutral, because we're not doing anything. It's from anatomical position, it's neutral position. We're going to call this flexion, again, neutral, and we're gonna call this wrist extension. The word hyper by definition means more than. So if I'm gonna press and go more than I normally would, this piece would be considered a hyperextension for me, or somebody have greater range of motion than average. That would be considered hyperextension. So somehow this description seen on the slide 23 is misleading, so please don't go with that one part of that slide. Okay. Vertical axis again explains the same thing what we already talked about. That is just again a refresher. Degrees of freedom, this is important concept. We're going to talk about that later as well. We have different joints, and every joint is responsible for doing its job. So how does the joint does its job? We can divide those joints into the what they can do. We call it degrees of freedom. So each joint could have as little as 1 degree of freedom and as many as 3 degrees of freedom. So simplest example, elbow. What can you do with the elbow? Well, you can flex it and you can extend it. One, if it goes up, goes down. One thing, right? Can you do anything else with the elbow? No, not by yourself. If the therapist is mobilizing you manually, and the therapist can elicit some accessory movement, which we're not going to discuss at this point, because it's not a voluntary movement. It's a passive movement, which is performed by outside force, by yourself. You cannot do anything with the elbow but flex and extend. 1 degree of freedom. The joints which we're gonna call it 2 degrees of freedom joints, or joint who has capacity of performing movement in 2 different planes using 2 different axes of rotation, is, for example, a wrist. What can you do with the wrist? Well, we already mentioned we can do flexion, we can do extension. That's 1. What's the second one? Ulnar deviation, neutral, radial deviation. Okay. Now, I'm trying to capture myself as well as I can. Okay. So 2 degrees of freedom. Now, some students ask me, what about this? What about this? I can do that. What is this? Well, this is a circumduction. Again, what is circumduction? Combination of both movements. So if I flex, extend, ulnarly or radially deviate, I combine those 2 movements, I can do circumduction. But circumduction, it's not a pure movement, it's combination of those 2. So wrist has only 2 degrees of freedom. And the third example is 3 degrees of freedom. Those are the more versatile joints. In this case, shoulder. Shoulder is the most versatile joint. Why? What can we do with the shoulder? Well, similarly, we can do that with the hip to a lesser degree. Unless you are a professional athlete, like or a ballerina, then you can do with hip what you can do with shoulder. But normally, shoulder it's more flexible than hip. For obvious reason. One is for mobility, the other one is more for stability. So what we can do with the shoulder: flexion, extension, abduction, adduction, and as I mentioned already before, external and internal rotation. 3 degrees of freedom. Again, circumduction is not a pure movement, it's combination of flexion, extension. Therefore we cannot say that shoulder has 4 degrees of freedom. It's 3. And the rotation looks like this. You can imagine the head of the humerus right now, right here, is rotating as you perform this type of movement. Okay? All right, let's go to the next slide. Osteokinematics. Well, we're gonna talk about bones now. We talk a little bit about joints. Now let's talk about bones. So we can do, let's say I am going to ask you, can you bend your knee? Well, kinesiologically speaking, this is a very vague question or demand or request, because you can do that in 2 different ways, which are very different, and the difference is more apparent, of course, for our patients. So we can divide any movement we are doing into closed kinematic chain or open kinematic chain. How I remember what is open, what is closed. If I don't touch anything, if I don't stabilize myself or anything, and I'm moving, and the end of my limb, either is an arm or a leg, it's free, it's open kinematic chain. But as soon as I stabilize the distal part of my limb, again, either arm or a leg, stabilize on something sturdy or sturdy surface, and during the movement I won't move the distal part of my arm or leg, this is called closed kinematic chain. So how can you bend your knee? This is the best example, or the example I could think of on slide 26. Closed kinematic chain. If I am going to ask you, can you bend your knee, you can actually go down on and touch the floor with your hands. Did you bend your knees? Yes, you did. Yes, you did. So it's a deep knee bend. but did you move your foot up in order to move your knee or flex your knee? No, you didn't. You used the floor as a very sturdy surface, and you did not move your foot from that sturdy surface. Therefore, it's a closed kinematic chain. The open kinematic chain is opposite to this. You can kick the ball, or you can lift your knee up. Did you bend your knee? Yes, you did. But how did you do it? Did the foot touches the solid ground? No, it doesn't. It's air between your foot and the surface. Therefore, it's called open kinematic chain. Let's give you an example with arms. I'm going to pick up an object and bring close to me. This is open kinematic chain because the distal part moves towards me. But let's say I'm gonna do pull up or push up. I'm going to grab something sturdy like a bar. I'm gonna grab it, and I'm going to do pull up. I'm going to pull myself up towards that bar, so the whole body goes up, but my hands are steady on the bar. So the distal part of my upper extremities are fixed when everything else goes towards it or towards my hands. That's called closed kinematic chain. So you got an example of both for lower and upper extremities. Okay, and you can divide any activity you're doing, and you can look at your joints and look at the movement, and anything you can do. You can say this is done in closed kinematic chain, this is done in the open kinematic chain. Okay, from kinesiological point of view, this is very important because bending knee, as you clearly see, it's not enough because you don't have the full picture of what's going on. So the next slide is slide number 27. So here you can clearly see what's going on when you ask your patient, for example, to bend the knee. All right. So as you look at this slide, the darker bones are moving, and the lighter ones, those are the ones which do not move. That's how the authors presented. So we're gonna describe that as you can see it. So the first one is also called. Let's take a deeper look at this picture. On the left side you have a A, and on the right side you have a B. So picture A, tibial on femoral perspective. Tibia on femoral perspective. Well, like I said just now, the darker bones are moving, the lighter ones are not. So clearly you can see that this is open or closed kinematic chain. Give you a second. It's an open kinematic chain. This person or that characteristic, it's kicking a ball, for example, imaginary ball, right? So in more precise terminology, it's an open kinematic chain, but what's going on within the bones, we're gonna call it tibia on femur. Okay. Now let's take into consideration picture number B, femoral on tibial perspective. So everything reverses, right? So again, the darker bone moves and the lighter bone doesn't. And the dotted bones, of course, those represent the movement. So what is this? A closed or open kinematic chain? Well, I'll give you a second. It's a closed kinematic chain, right? Because the distal part is sturdy on the floor. It's planted, right? When the proximal part is moving, okay? So I hope you by now have a solid understanding of open and closed kinematic chain, okay? Let's go back to arthrokinematics. What the joints can do, how do they move, right? So the joint can move in as a roll, slide, or a spin, okay? Also, the joint can be in closed packed position or loosed packed position. So when I am trying to catch the best picture. If I am flexing my elbow and now I'm going to tight my muscle, very, 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 very tight, and you as a therapist trying to perform a passive range of motion, passively move my elbow to any direction, you really would have a hard time, or would be almost close to impossible, because I tightened all my available muscles and I won't allow you to do it. So it's the joint itself is very packed, and that's how we call it, closed packed position. To the contrary, when I loosen up my muscles, you can now passively move me easy, and those muscles are semi-relaxed, of course. So we're gonna, this joint is affected by muscles, directly affected by muscles, and this position would be called a loose packed position. Okay, let's talk about this slide over here, which is roll, slide, and spin. Roll, slide, and spin. Okay, let's talk about roll. Multiple points contact multiple points on the surface. Okay, so to imagine this, perhaps imagine a tire of your car. When the tire of your car moves like this, right, and goes forward. So multiple points on the tire are touching multiple points on the asphalt. Okay, so this is a classic example of a roll. This way. Then is slide. Slide is when the single point of contact, single point of one surface is in contact with multiple points in the other surface. Well, imagine the same tire, not in Florida, but in northern part of states. In the winter time, there is snow, there is ice on the road. You must hit the brakes. You hit the brakes hard. How the tire will behave? Well, the tire will stop moving. You lock it with the brakes, but the car doesn't listen, and it just glides forward. Right? Imagine on the ice, right? Hitting hard on your brakes. One point of the tire touches multiple points on the asphalt. That's slide. Spin. What is spin? Well, imagine now, can't do tire anymore. Let's imagine a little toy, child toy called top. So you spin the top, and the top is running like this. So one point of that top touches only one point of the surface. So that's how our bones work as well. One bone attaches to the other bone, and they either do roll, slide, or spin, or combination of two. Okay, so we're gonna talk about those combinations in a second. And in future presentations, because every joint does either one or more, and we're gonna talk about individual joints. Okay, so let's go to the next slide. Each surface of the bone is either concave or convex. Concave or convex. So convex member rolls and slides in opposite direction. This is like a rule of a thumb. Right, so convex on concave, and I'm going to explain this in the future or the next slide. So convex on concave, convex member rolls and slides in opposite direction. But in a case when the one bone is concave and the other one is convex, so concave on convex, then concave member rolls and slides in similar direction. Okay, those are just words. It's probably difficult to picture without actual drawing. So let's go to the next slide, which is slide number 31. So you can see clearly that we are dealing with femur, and we're dealing with tibia. So let's take a deeper look at that. Again, darker bone moves and lighter bone does not, and you can see the very light portions, those represents the movement of the bone itself. So first and foremost, we have femur which moves on the picture A, femur which moves and tibia does not. Right away you know that this is either open or closed kinematic chain. I give you a second. It's closed kinematic chain. Okay, so this is, let's say, squat. You're doing a squat, right? So femur moves, and in this case femur goes into extension, right? Femur goes into extension. So how tibia is fixed, tibia doesn't move, so there is no need for us to discuss tibia. It's planted on the floor. But how the femur behaves, as you can clearly see on this PowerPoint on the picture, femur rolls one way, but at the same time, not to get dislocated, pulls back at the same time. So it rolls, but at the same time slides back in order to prevent dislocation. Okay, let's take a look at the picture B, which explains extension, but this time extension of tibia. So close or open kinematic chain. Give you a second. Open. You're kicking the ball, imaginary ball. So as you can clearly see, that femur would be considered concave or convex. Convex. And tibia would be concave or concave or convex, right? The other way around. So now when we're talking about the tibia rolls, but at the same time slides in the same direction. You can ask me, well, if it rolls and slides in the same direction, how come doesn't dislocate? Well, this is the role of your ligaments and your muscles, and that's why when you play soccer or other sports, those athletes have great problems with ligaments, right? So you can go back to the slide before. Let me just adjust this. Go back and to the text. Concave, convex on concave. Convex member rolls and slides in opposite direction. So you can clearly see that convex on concave in the picture A, that's exactly what's happening, because the femur moves and the tibia does not. So it's convex member rolls and slide in opposite direction. And in picture B is just the opposite. So let's go back one slide. Concave on convex, again because tibia moves and femur does not. Okay, so concave member rolls and slides in similar or the same direction. Okay, type of movements, we all are very well versed at this time: passive, active, assistive, and active. Active is of course when patients are doing everything by themselves. Passive is when they don't do anything and therapist must perform that movement for them. And active assistive is the movement when a therapist partially helps patient. Very important concept. Why? Because in manual muscle testing, perhaps more so, but with goniometry, with range of motion, we do not take into consideration active assistive range of motion. Why is that? Well, patient either can or cannot do it. If patient can do something partially, you can't really document how much help the patient received. So it would be very difficult to assess that, and we just simply don't do that. So when we are measuring range of motion, pay attention. Is always you always start with active, and if the active is not possible, then you do passive. Active assistive, we just simply do not do it. Okay, let's go to the next slide, which is center of mass. We're gonna talk about gravity later. This is just heads up. So it's a point which weight is considered to be centered. So in man is in approximation, of course, approximately second sacral vertebra, and this is taking into consideration normal weight. So in women is slightly lower, perhaps as much as inch or so. Why? Because of the larger, therefore heavier pelvis or hip area. And you can put yourself outside of the body, outside, not yourself outside of the body, but the gravity outside of the body. And we actually using this, we utilizing this as we are walking or running. But we will talk about that later in greater depth. This is just heads up. So center of gravity can determine the segmental centers of gravity, center of gravity of extremities. So either you can take into consideration the center of gravity of entire body, which we just said is either a second sacral vertebra or a little bit lower for women, or you can take each part of the body separately and measure the center of gravity, for example, of an arm or leg. Okay. And of course, the center of gravity changes when length of the extremity changes. Again, we will talk about this in the future in much more extensively, but let me just try to demonstrate this for you. So this is my full length of my arm. So you can imagine the center of gravity is somewhere in here. A little bit maybe above the elbow because the upper part is bigger, thicker than the lower part. So perhaps somewhere around the elbow or a little bit above it. But as soon as I fully flex my elbow, then what's happened? That this is not a point of gravitational pull anymore because it's not the center of the mass. Now the mass starts here and ends over here. So where is the center of gravity? It must be the half distance from point A to point B, meaning perhaps somewhere in here. So it's the center of the mass moves here, okay? And of course the last slide of this presentation is when you can see that the center of gravity is in it's marked A, but we can also take different parts of the body into consideration by themselves and find the center of gravity of those body parts, which here it's represented by B and C. And this concludes my presentation of the PowerPoint kinesiology. I hope you get some important information, some understanding, some clarity from my presentation, and I will see you soon. Thank you.